Assalamu alaikum, I am Dr. Junaid Jahangir Abbasi, and today I am going to tell you how to approach a patient with obesity in a short case. You may be given the command of doing general physical examination, and when you will come, you will notice that the child is obese. At that time, you must be knowing how to differentiate between obesity and edema. So you may not think of the case as a case of nephrotic syndrome. Rather, you should know that this is obesity. In a case of obesity, first of all, like all the short cases, have an overall look of the patient and just do inspection for a period of 30 seconds with a proper exposure. During this period of 30 seconds with proper exposure, also talk to the patient so that you may know about the intellectual impairment of the child. See whether he is interested in the surroundings. See whether he's maintaining an eye contact. See whether he is responding to the commands. Obesity with intellectual impairment, think of Prader-Willi, Bardet-Biedl, Down, Froelich syndrome, hypothyroidism, pseudo hypoparathyroidism. See whether the child is active or he's sleepy. Obesity with sleepiness, think of Pickwickian syndrome. Have an overall look at the skin of the patient. See whether is there any bruises, poor wound healing, stria, bruises, poor wound healing, stria on the skin, think of Cushing. If Cafale spots are present on the skin, think of McCune-Albright syndrome. See where is the obesity, what is the distribution of obesity, whether it is truncal obesity or whether it is an overall obesity. Then on inspection, get an idea whether the child is short stature or tall stature. Obesity with short stature, think of either endocrinal cause or a syndrome like Turner syndrome. Obesity with a tall stature, think of simple obesity or Klinefelter syndrome. Then once you have done with the overall inspection of the child, ask the child to walk and see the gait of the patient. Obesity with a limp in the gait, think of slip capital femoral epiphysis. If the gait is normal, ask him to bend down and see the spine. See whether is there a buffalo hump present. Buffalo hump is actually a pad of fat in between the scapula. See whether any kyphosis or scoliosis is present. You may have kyphosis or scoliosis due to prolonged steroid intake, because steroids they cause osteoporosis. Check the spine for tenderness. Osteoporosis can lead to a tender spine also. Overall inspection, the gait, the spine, and then ask the child to do the Gower sign. Sit down and then stand to see the Gowers. Steroids leading to Cushing syndrome can have a positive Gower showing proximal myopathy. Once you've done with this, do the anthropometry of the child, the height, weight, and the head circumference. Plot them down, and you should have a calculator with you. Find out the BMI. Small calculator, you may put that calculator in your examination bag. Then start from the hands. In the hands, see whether the hands are small, as seen in Prader-Willi, any simian crease for Downs, any polydactyly for Bardet-Biedl, or a scar of polydactyly operated. In the hands, also look for short and curved fourth metacarpal, which is seen in pseudo hypoparathyroidism. Then from the hands, go to the pulse. See whether the pulse is slow as seen in hypothyroidism, or it is bounding as seen in carbon dioxide retention in Pickwickian syndrome. Then see the blood pressure. Obesity with hypertension, think of Cushing. Obesity with hypertension, also think of hypertension as a complication of obesity. Then axilla. Note down the stria in the axilla. The Akanthosis nigricans can be associated with obesity, leading to impaired glucose. Then go to the head. In the head, measure the size and see the shape. So measuring the size and looking at the shape of the head is important. Let's suppose the shape of the head is enlarged. Obesity with a large head, think of space occupying lesion, think of hydrocephalus. See the shape of the head. If there is prominent forehead and bitemporal narrowing, think of Prader-Willi. Then see the hairs. The hairs are dry and easily pluckable in hypothyroidism. The hairs are oily in Cushing. Then see the face. Face is moon-like in Cushing. Face is round and having an immature look in growth hormone deficiency. Face has plethora in Cushing and as well as plethora in polycythemia of Pickwickian. Face has telangiectasias in Cushing. Face has coarse features in hypothyroidism, and face has Down's features in Down syndrome. Then see the eyes. In the eyes, see whether there is loss of outer third of the eyebrows. If there is loss of outer third of eyebrows, think of hypothyroidism. See whether the eyes are almond shaped. If they are, think of Prader-Willi. Also in Prader-Willi there is squint, so look for squint. Look for apicanthal fold seen in Down syndrome. Look for the upward slanting of the eyes in Downs. Check the visual acuity. If the visual acuity is impaired, think of Bardet-Biedl, think of Froelich syndrome, think of Elstrom syndrome. These are all syndromes associated with obesity. If you find bitemporal heminopia in the eyes, think of pituitary tumor. Pituitary tumor can have obesity also. For Cushing, look for cataract in the eyes. Look for retinitis pigmentosa. Obesity with retinitis pigmentosa, think of Bardet-Biedl, think of Elstrom syndrome. And at the end, tell the examiner, I want to do fundoscopy, because fundoscopy with obesity is important for having pituitary tumor, having benign intracranial hypertension. Benign intracranial hypertension can be seen in Cushing. Also, you may have hypertensive retinopathy in Cushing. From the eyes, come to the nose. Check the patency of the nose. If there is anosmia, obesity with anosmia, think of Kallmann syndrome. If there is a midline groove, midline dimple, think of hypopituitarism. Then see the mouth and the chin. If the upper lip is triangular, think of Prader-Willi. If there is central cyanosis, think of Pickwickian syndrome. See whether there is cleft lip or cleft palate. Look for candidiasis. Prolonged steroids or Cushing can have candidiasis. Look for the dentition. Delayed dentition, you can have hypothyroidism. See the tonsils. The size of the tonsils may be enlarged, leading to upper airway obstruction and hypoxia and hypercapnia in Pickwickian syndrome. Then see the chin. If there is micrognathia or micronathia, whatever you pronounce it, think of Prader-Willi with micronetia. If there are facial hair or acne, it can be with Cushing also. Then once you have done with the head, eyes, nose, face, chin, teeth, come to the neck. See whether there is goiter. If there is goiter, think of hypothyroidism. Plus, note down any webbing, because obesity with short stature and webbing of neck, think of Turner syndrome. Also, the supraclavicular halo may be obliterated in Cushing due to fat deposition. Fat pads are there. Plus, see the JVP in the neck, because Pickwickian syndrome can have right ventricular failure leading to raised JVP. From the neck, go to the chest. In the chest, look at the breast. Establish whether there is gynecomastia. You may have gynecomastia. In the chest, also look for a right ventricular heave, because Pickwickian syndrome can have right ventricular failure. Also look for stria in the chest. From the chest, go to the abdomen. In the abdomen, look for stria and palpate for adrenal masses and palpate for hepatomegaly. Hepatomegaly may be found in right ventricular failure. Adrenal mass is important in abdomen because Cushing syndrome may be due to adrenal tumor. Hepatomegaly is important because right ventricular failure can be seen in Pickwickian syndrome. From the abdomen, go to the genitalia. In the genitalia, first of all, establish whether the genitalia are advanced or they are delayed. If there is advanced development of the hair or the phallus, think of Cushing, think of hypothyroidism. If there is delayed development of the hair or phallus, also consider hypothyroidism. Hypothyroidism can lead to both advanced development and delayed development. But Cushing will always have an advanced development of the hair and phallus. Also note down whether the size of penis is small and the gonads are small, because if the gonads are small, that is if the patient is having hypogonadism, then obesity with hypogonadism, you should have 4 differentials in your mind. One is Prader-Willi, the other is Bardet-Biedl, the third is Froelich, and the fourth is Klinefelter syndrome. You may have Kalman also. In fact, 5 differential diagnoses. From the genitalia, you can go to see the spine if you had not already seen the spine. If you have already done with spine, go to the lower limbs. In the lower limbs, note down any abnormal stria, and then measure the length of both the limbs to see whether if there is leg shortening. Then do the external rotation, see geno valgus or varus. Hold arms up against resistance to see proximal myopathy in Cushing. Also, when you do the external rotation, also do the abduction of the hip. In short, assess the range of movements at the hip, because obesity can lead to slip capital femoral epiphysis, leading to avascular necrosis of the hip, leading to limitation of the movements at hip. So in your lower limb, you should be concerned about the leg shortening and the avascular necrosis of hip, slip capital femoral epiphysis. And when it comes to the motor examination, just do the reflexes, and in the reflexes, you should be looking for delayed relaxation of the ankle jerk. If there is delayed relaxation of the ankle jerk, think of hypothyroidism. After this, cover the patient and say thank you so much, and get ready for the Viva questions. The Viva questions may be, what is your differential? What is your second differential? What is your third differential? If there are no dysmorphic features, if there are no signs of Cushing syndrome, say it is a case of simple obesity. If you found stria, pad of fat in interscapular region, hypertension, cataract, things like this, moon-like face, say my diagnosis is Cushing syndrome. If the patient has obesity and there are signs of dysmorphism either on the face or in the eyes or whatever I told you, say it is obesity associated with a syndrome. And then when he asks you which syndrome will you consider, then among these syndromes, consider the most relevant syndrome according to your case. If your diagnosis will be Cushing, then most of the Viva will be about Cushing. What are the investigations of Cushing? What is dexamethasone suppression test? What are the levels of cortisol in the morning? What are the levels of cortisol at midnight? Like you should know that cortisol levels are peak in the morning and they will be low at the midline. And when you do give dexamethasone suppression in Cushing, the cortisol will not be suppressed with the low dose dexamethasone, but with a high dose dexamethasone, the cortisol will be depressed in Cushing disease, but not in Cushing syndrome. So this is the way you differentiate between Cushing syndrome and Cushing disease. And also with the help of dexamethasone suppression test, you also differentiate between whether it is simple obesity or Cushing, whether it is stress or a depression, that is elevation due to any psychological factors or stress. So dexamethasone suppression and its interpretation is very important. Then the examiner may ask you, how will you treat Cushing syndrome? How will you treat simple obesity? What can be the complications of obesity? What are the long-term complications? What is the short-term complications? What lifestyle modifications would you advise? What dietary modifications would you advise? So this was all about approach to a patient with